Dr. Larry brings you another segment of Did You Know?
We've all heard somebody say, I got a bad hip, knee, or spine. Or maybe we say it about ourselves. In addition, commonly in healthcare, there's a lot of chit-chat about that. We ache as we age and our joints begin to rage. And eventually, at some point, many of us will have to address some type of bone and joint issue. And maybe you hurt so bad you need a Kleenex or a tissue. Or maybe you're the weekend warrior or athletic type. And after many years, you know that noise or pain in your body just ain't right. So where do you go for a joint that's screaming no? Well, it's a field of choices. But when it comes to choosing an organization of doctors for something as important as sports medicine or injections, you want to pick a facility that has its processes and people operating to win. Because it's the style of this organization, OSMS, that separates them from the rest. They are doctors who not only own their clinic, but actually focus on the patient. So pay close attention to part 2 of our interview with Dr. Harper. As you heard, he's a practicing physician, singer, I had to throw that one in there, non-operative specialist, board certified in the field of bone, joint, muscle care, and he specializes in guided joint injections, bracing, and regenerative medicine, which was the main focus of our show last week, and we'll finish that up today. So for the sake of simplicity, I called the segment Ask OSMS. And you'll have to stay tuned, and until then, take a little rest. Guided injections, regenerative medicine with Dr. Michael Harper when we get back from the break. Stay tuned. You're listening to the Dr. Larry Radio Show. We'll be right back.
Dr. Larry will be back in a moment. Breaks over. Time to get cracking once again with Dr. Larry.
Welcome back. This is Julia Childs. I'm just kidding. You don't even know who that is. Oh, cooking lady. British. No, I'm interviewing Dr. Michael Harper from OSMS. We are getting a good dose of info on this musculoskeletal pro who treats you non-operatively with issues from shoulders, elbows, hips, or a banged up knee. And in part 2, we'll be diving more into the types of conditions he treats non-operatively with his procedural expertise. And before we jump into that, you're gonna hear a little bit about dequar veins, which is basically like swelling of the thumb. Let's listen to and have us tap into the treatment world of regenerative medicine, which is coming up as well too, which Dr. Harper utilizes, and what he's finding through research and clinical cases, that there's a common pain. You'll know what it is when you hear us talk about it. You're going to know that's potentially safer and more effective treatment versus steroid injections. This is a particular problem that regenerative medicine injections can help with. You're going to want to hear this in just a few minutes. Roll it.
Okay, so you use ultrasound, but you also do carpal tunnel injections as well. Is this something that where somebody has carpal tunnel syndrome, they're exhibiting signs and symptoms, you've proved that it is, and maybe they're just short of a candidate for surgery as far as that goes, for carpal tunnel release, then you do guided injections for carpal tunnel as well?
Correct. Yep. And so for multiple conditions, and one of them is carpal tunnel, that if we have identified that as the diagnosis, doing injection around that area can really help. And especially if somebody's not ready for surgery. And so there's times where, like, yes, you're a surgical candidate for carpal tunnel release, but it doesn't work within their lifestyle and their timeline right now. They can't take their time off of work or et cetera, that we can temporarily help with some of the symptoms with the injection.
Okay. What about something like, same thing as like dequar veins?
Yep, absolutely. And that's what I like about using the ultrasound for dequar veins, is that we have found that if we put certain types of medications directly into tendons, that they actually have a negative effect. And so particularly steroids, that if we put it directly into a tendon, it increases the risk of further degeneration of the tendon as well as rupture. And so the ultrasound allows me to put it in the tendon sheath. So it's not directly within those tendon fibers, but just around that tendon to help calm down inflammation, but reducing some of the negative side effects as if I was putting the medication right into the tendon itself. And that's really difficult to do unless you have the image guidance to have that precise location.
So this is a side question coming from me, just because it's interesting and based on patient questions that I get as well too. What percent overall would you say? Let's stick with carpal tunnel and decore veins. And folks, decore veins is basically your sore thumb tendon that gets to the point where your tendon, the thumb itself doesn't work well. I call it the cousin to carpal tunnel. It's not the greatest way to say it, but people kind of get it. How often would you say you use ultrasound-guided injections for, let's say, those two things versus not? Is it all the time, some of the time?
Yep. So,
good.
Yep. Every time I do an injection like that, I'm using image guidance. Because it's safe and effective and it's fairly quick to do in my clinic and I have it readily available. It just makes sense to do that injection with the ultrasound guidance. That's how I've been primarily trained as well. And so my recommendation, if we're doing a carpal tunnel injection, at least in my hands, I want to have that ultrasound.
Fantastic. Okay. Let's jump into fluoroscopy. If you could help us understand what that is and maybe tell us what the difference is between ultrasound, and then kind of guide us through what fluoroscopy is and the 1 to 3 benefits for the physician and or the patient as well.
Yeah, so fluoroscopy is also kind of like known as an X-ray guided injection. So it allows us to have a better picture of the bones that we're dealing with. And so it really helps us visualize certain types of joints, as well as then different types of injections that we can do into the spine that are a little bit deeper than an ultrasound can really penetrate. And so it helps us see more depth than an ultrasound sometimes can do. Some of the benefits of doing fluoroscopic guided injections are really similar to the ultrasound guided injections, that it improves safety, it improves efficacy, and a lot of times it'll improve patients' comfort as well. And so we just use it for different types of things. There's some that we use it for both, like a hip injection. You can use both fluoroscope or ultrasound. But if you're doing what's called an epidural steroid injection, so I'm putting numbing and steroid medication around a nerve in the spine, I want to use an X-ray because the ultrasound just doesn't give me a clear enough image. And what the fluoroscope or that X-ray does is allows me to get the medication right where I want it to go. What's also unique about fluoroscopy is we use some contrast dye, and we can see actually where the fluid is flowing within these potential spaces, like that epidural space. And so it really helps precisely put the medication where we want it to go and improve safety.
So as far as, if I can break this up into 2 categories, ultrasound would be most used for and useful for soft tissue. Fluoroscopy would be for bone or hard tissue, basically. Or did I overgeneralize?
It is a little bit more nuanced than that too.
Okay.
Yep. And so for major like extremities, for the most part, I use an ultrasound for. So a shoulder injection, an elbow injection, a wrist injection, a hip injection. In my practice, the fluoroscope really comes when we're treating the spine and doing like either an SI joint injection or where we're targeting the joints within the back, just because there's some deeper structures there. But there's a lot of overlap as well. Like you can do a shoulder injection under both guidances. And whichever one kind of your practitioner is most comfortable with is normally what I say do and recommend. I do it under both, and it kind of whatever makes sense for me and the patient and the schedule to be able to get it done.
Perfect. Well, and thanks for highlighting those 2 things for us. And I'm glad that you said you use it all the time, because that's how you're trained. That's what you know how to do. I always feel like, when you're trying to, you got a patient there that's highly symptomatic. Maybe they've, haven't responded to conservative care. They're in your office. Now it's time for the big stuff. And if they got a chronic shoulder thing going on, or like you said, an extremity thing like a hand or wrist, then somebody like you can get in there and use the visuals to see where you need to go. I like how you described the sheath, because this is something, as a chiropractor, I get this question quite frequently when it comes to injections. Dr. Larry, won't the steroid hurt my muscles? And I said, well, it's low occurrence, and right now, let's say it might be your first time or second time. Don't worry about it. But what you just highlighted, it's being around the sheath versus within the tendon that kind of makes the difference between where the medications put. So thanks for bringing that out. I did want to carve some time out for something that is actually in your bio that you do, which is orthobiologics or regenerative medicine. And I know the second thing is going to really kind of capture people's attention. I would like for you to describe what that is, how it works, and what type of patients you see that are good candidates for this. This regenerative medicine thing started coming into, I guess, fruition and light, and I started getting questions about it probably 5-ish years ago in my office. And I know sometimes in other states it's done more frequently, but ultimately this really is something I wanted to carve out some time to help. I've never had anybody on the show explain this to all of us, and there's kind of a grab bag of information out there. So if you could kind of straighten that all out for us, what regenerative medicine is and how does it work and the types of patients that are good candidates.
Absolutely. And so, there's two terms that you might hear, orthobiologics and regenerative medicine. And they kind of are used relatively interchangeably. But mainly the focus of it is that we're using somebody's own cells to help stimulate a healing response or optimize the environment that a certain tissue is in. The main workhorse of orthobiologics and regenerative medicine is what's called platelet-rich plasma. And that's where we take somebody's blood, we spin it down into a centrifuge, and we can separate the different types of cells, and we kind of take just the platelets and then the signaling and healing factors that go along with them, and we can use them to optimize the environment of our tissue target. And so the platelets themselves, it's like when you get a cut on your arm, that's what helps heal that cut and kind of make that scar, and then eventually get some remodeling of those collagen tissues. And so the same idea is we're taking that PRP and that platelets, and we're getting a concentrated dose of it and putting those healing factors into a tendon or into a joint. When we put it into a tendon, many times it is to try to stimulate a new healing response. Multiple different parts of our bodies, including tendons, don't have the greatest blood flow. And a lot of these chronic tendinopathies like tennis elbow or Achilles tendonitis, they stick around for a long period of time. And the big part of it is it's a failed healing response. Your body's just not able to heal itself on its own. And so what we kind of do is we put platelets in that area to jumpstart that healing response and use your own body's healing mechanisms to improve and get you moving in the right direction. We also use it for joints. And so when we put this platelet-rich plasma into a joint, we actually, interesting enough, we see an opposite effect as if we put it into a tendon. You put it into a tendon, it causes inflammation and healing. When you put it into a joint, it's actually an anti-inflammatory. When a joint's inflamed and irritated, you can hear about some different types of arthritis or inflammatory type of arthritis. Well, the PRP can help calm down inflammation. And it's just very unique about what our cells are able to do based off of what environment that we put them in, that they're pretty amazing what they can optimize and help improve. And so utilizing for those two different ways, we utilize PRP. And so you might also hear about different types of cells that can be used, and stem cells is another term that is commonly utilized. And the most common, when I use stem cells in quotations, are from your bone marrow as well as from like fat cells that people are using to inject. And we have seen that we do see some benefit with utilizing some of those tissue types, but it's more so the stimulating molecules that come along with the cells that they're taking. And the cells themselves are not true stem cells that they're going to regrow and make new cartilage for somebody. We just haven't seen that in the data, but it is still optimizing that environment that it can help improve pain and function. Particularly when we're using like platelet-rich plasma, we've seen that there's different inflammatory markers inside a knee, like IL-6 and TNF-alpha, which are different inflammatory markers, can be decreased even a year after the injection. And so we're seeing these injections are more effective. They're lasting longer than sometimes than steroid injections are these common ones. And also they don't have the negative side effects that steroids have. We are learning more and more that some steroids, when we do repeat injections, can actually make that tissue target worse. And we're not seeing that with these orthobiologics and within regenerative medicine.
Perfect. I'm glad you answered and kind of laid that all out, just to hear it from the clinical side of things, because I think it's one of those situations where there's just a bit of a nebulous concept of really what it is out there. This kind of haziness to it. So, and which is going to allow us to really jump into some successful cases we had, and we're going to go through 3 of them. one of them will be regenerative medicine, but now that already kind of has us focused on what it could be. Like you mentioned, tennis elbow, knee issues, and then targeting the certain inflammatory markers. But yeah, I'd love to hear now some successful cases that you have had with your own practice. And let's just start off with like an ultrasound-guided case. Let's hear about the case, the patient, and what you did. Cases are like icing on the cake, the jelly inside the donut. What the jelly is to a peanut butter and jelly sandwich. Yeah, Reed, I see you about on that head up and down. You hear him talk about the PRP injections and the stem cell stuff. I was inundated with questions like this 7 years ago. And my response was, hold tight, wait it out. Don't throw too much money at this, because this is an opportunity for practitioners sometimes to overstimulate the benefits and charge a lot of money for it. So here we are, fast forward 5 to 7-ish years later. And what I did was brought up this question to somebody that has this in their tool box and has vetted out what works, what doesn't work. And so now this is something where you would talk to a practitioner like Dr. Harper and see if you are a candidate for this type of injection as well. Again, he does other ones, but in this case, like I said, this was a thing I was getting a question about many years ago, and they just said, sit tight, wait it out, like I said, because then what will happen is all the fluff and hype and circumstance and the money flying around for these procedures, we don't know if they work or not, and while there's good hope on it, but like now there's some better concrete evidence that's what does work. And like you heard him mention, tennis elbow is one of them, but there's some other things they can do with regenerative medicine. And OSMS does it, and they're overall very fair. They're a big orthopedic clinic, but they have you in mind as well too, as far as their patient care goes. And I've brought a couple of these physicians on over the last 12 months, and they've got a kind of a genuine appeal to them as well too. They're personable, and so they'll talk and walk you through if you have questions about this. And I would ultimately say, if you do, that's when you're going to call them and talk to them about that. So it's got some interest now, hopefully again in your mind. And if you're suffering from some of these chronic inflammatory problems within your joints and just not having success with it, this would be another alternative to that as well too. So 3 successful case examples: ultrasound, fluoroscopy, and regenerative medicine cases are coming up when we get back from the break. Stay tuned. It's Did You Know with Dr. Larry on WIKB. We'll be right back.
We'll be right back with Dr. Larry. We're back with Dr. Larry.
Welcome back. Kata. Dr. Harper and I are discussing some successful cases with people who have pain and probably grimaces on their faces. Let's hear how he flipped over the card and got some aces. Roll it. Let's hear about the case, the patient, and what you did.
Absolutely. So, patient I had was a female that was in her 50s that was having pretty bad knee pain. She'd been dealing for many years, had tried multiple different types of injections. None of them had been with image guidance. And so she'd had a steroid injection. She had had the hyaluronic acid or those gel shots. Many people call them the rooster comb injections. And she'd also had actually some regenerative medicine. She had had PRP. And unfortunately, none of them really worked. And so when those things weren't working, she was seeing me like, what other options I have? I don't want to have a knee replacement. And so I used my ultrasound and I scanned, and I saw she had not only a large joint effusion, a lot of fluid, but she also had a fairly large Baker cyst that was symptomatic. And what a Baker cyst is, it's a collection of fluid behind the knee, and it can cause quite a bit of pain when you're bending that knee. And so what we ended up doing was we took the fluid out from her knee joint, as well as then we took the fluid out of that Baker cyst. And then I also put some steroid in the joint to help decrease the inflammation and hopefully reduce the amount of fluid that's going to be coming back. But when she got off the table, she was just amazed. She said it was the best she had felt in 2 years with getting that fluid off of her knee. And without the ultrasound, one, it's difficult to get all of the fluid that we need to, particularly that Baker cyst that's in the back of the knee. You got a pretty important blood vessel and nerve that lives back there that you don't want to be just digging around with. So the ultrasound helps make sure I stay away from those things and I can just focus on draining that fluid off.
The Baker cyst, you didn't go there. That is fantastic. I could probably think of 3 dozen people right now that have a symptomatic Baker cyst walking around, and they're like, "That's my Baker cyst, Dr. Larry. It's killing me." And and one of the maybe you probably have heard this as well too, just from Joe Public, but isn't it kind of the theme out there that's like, I got a Baker cyst, but they won't do anything about it. But like you just said, you had a symptomatic Baker cyst that you successfully treated. The lady got off the table and she was great.
Yep.
Perfect. Okay. So and I got 36 patients in my head right now that are nodding up and down, and a chunk of them might be listening to this. And so the Baker cyst, successful, ultrasound guided. How about fluoroscopy? Now we know what it is. It's going to be probably spine, but I'll let you tell us, not me.
Yep. And so I've had a few patients that kind of fit this category, but one of them that comes to mind in particular was a 60-year-old male, and he was coming in and he actually wanted to see one of our surgeons because he was having groin pain, and he was thinking, all right, he might need my hip replaced. And one of our surgeons evaluated, and like, yeah, you got mild to moderate arthritis in that hip, but he wasn't positive that the hip was actually the primary pain generator. And sometimes back pain and pitch turn to the back can mimic other joint pains, whether it be a knee or a hip or an ankle. And so initially they had sent him to my office, and I did a diagnostic ultrasound-guided hip injection for him with just numbing medication only. Say, is it your hip pain or is it something else that we need to be looking up? And we ended up doing the injection, and he got off the table and didn't really feel a whole lot of difference in his symptoms. And so we decided, let's look at your back more. We had gotten images, and an MRI actually showed that he'd had a disc herniation that's pinching on his L3 nerve that correlates to hip pain, and particularly the anterior and the front of the hip pain. And so what we were able to do is we did a fluoroscopic guided injection called an epidural steroid injection, where I was able to guide the medication down safely around that L3 nerve for him, got the medication in along with some numbing medication and steroid, and we got the table, his pain was gone. And he was super thankful because he had come in the office thinking he needed to have a hip replacement, and we were able to make him feel better with teaching him some exercises as well as doing this injection for him to get it calmed down.
Yeah, that pain pattern requires that differential, doesn't it? That can be a little bit of a catchy one. Hip versus back versus someplace else.
Absolutely.
And then the final the regenerative medicine case. I can't wait to hear this one because it's not something that is still often done or talked about. I can only think of maybe a handful of patients that actually have had some type of PRP injection, but I'd love to hear a case on that as well.
Absolutely. So PRP, like you had mentioned, it's been around for many years. The majority of the data was initially developed around tennis elbow, and that's where I see a lot of the majority of my success is utilizing it for tennis elbow. We've actually gotten to the point where we're considering that for somebody that develops tennis elbow, should that be one of the first line treatment options over a steroid injection? And so I'd seen a patient that was about 44 years old. He had been dealing with this lateral or outside of elbow pain for about 2 years. He'd been through physical therapy. He had already had 2 or 3 steroid injections to that area. And each of those injections provided some temporary relief, but nothing long lasting. He was just getting frustrated that this kept coming back, and ultimately he had recently gotten an MRI that showed there was some partial tearing of actually the extensor mass, or those tendons that are attaching around where that pain is for tennis elbow, also known as lateral epicondylitis or lateral epicondylosis. There's some technical terms that we'll throw at you, but the patient, he was frustrated. He was talking with other surgeons and said, well, one option is to do surgery, but another option is this regenerative medicine. And so he referred him my way, and we kind of talked about what PRP is and kind of what the rehab process is afterwards. And he opted to try it. And we did what I call a needle fenestration, where I just kind of put some small holes within that tendon, and I put then within those holes, I put the PRP in. And a few weeks later, after I was seeing him in the office, he's like, oh, my pain is gone. And so he actually was one of our early responders. Normally, when we're treating a tendon, tell patients to expect it's going to take about 6 to 8 weeks to see a significant difference. But I saw him about 3 weeks later, and he's like, I'm feeling fantastic. I'm feeling great. And he was super excited that he's like, I might not have to do surgery on this now. And so we went and had him complete the therapy protocol afterwards, and it saw him back at 6 months, and things were feeling fantastic. And he didn't have to he didn't have any pain anymore. He was able to get back to his everyday life and do the things that he wanted to do. He wasn't a tennis player, but he was able to get back into doing a lot of the sports and activities that he'd done previously.
Yeah, just because it's tennis elbow doesn't mean he was a tennis player. It's some of these terms that,
exactly,
that you and I both know that come out. It's like golfer's elbow, tennis elbow, Finkelstein's test. I mean, all these tests with their names to them as well. You got to translate it to modern English and be like, yeah, your elbow hurts. So, folks, whether it's a tennis elbow, a knee issue, it's a shoulder problem, and if you're looking for expert non-operative care, as you just heard, that's where Dr. Harper's sweet spot is. And then he defined for us what regenerative medicine is and the function of it, and what they're seeing high success cases, which is in tennis elbow as well, too, and you don't have to be a tennis player. Dr. Harper, if listeners want to contact you for an appointment, what is your phone number at OSMS? And let's give us the website as well.
Yep. And so our clinic number is 920-430-8113. And then how to get to our website, which you also can make appointments online, is www.osmsgb.com.
Dr. Harper, thanks again for coming on the show, highlighting the things that you do and some of the success cases, and look forward to having you on again at some point talking about some other cases.
Yeah, thanks for having me.
You bet.